Betty, this is Dr. Carey again, and I have a mini lecture for you today. It's the inflammation mini lecture, and we're going to talk about how these cells that support inflammation are useful, but also, more importantly, how they contribute to disease. And while their functions are supposed to be effective within the body, they can sometimes not be. So there's four types of hypersensitivity reactions. A hypersensitivity reaction is basically an allergic reaction. We're going to talk about each of these types. The first and the fourth are described pretty much by their title, immediate and delayed. And then we have type 2 and 3s. Type 2 is a cytotoxic, and type 3 is an immune deposition. And those differ quite a bit as well. The processes actually are different within each of these, and so we see that the cell types may be similar, but things happen in a slightly different way, which make the different types of hypersensitivity reactions. So for this presentation, we're going to talk about 6 steps, and I use quite a few of the images that are in your textbook. If you want to go back through and look at these images later, you can do that. Those images are helpful, but I want to make sure that we can break it down into steps so that it makes sense and not be overwhelming, so I eliminate steps that you don't need to actually see. So step 1 is just this antigen, and an antigen provokes an antigen presenting cell, and anytime they use a word like provoke, it means attack or attaches or aggravates. So this antigen comes to the APC cell and it attaches itself, it provokes it. Then we see that in step 2, the APC presents itself to a CD4 cell. And that you've heard of CD4 cells before. They're the T helper cells, and they work in a lot of inflammatory and infection processes. That T helper cell then excretes cytokines, and the cytokine is an important word that you should remember as we move through this unit. Cytokines are useful in many instances, but they're also a excreted product that we might use medications to block. Same with histamine, which we'll talk about in a little while. The cytokines provoke or attack B lymphocytes, and those B lymphocytes then, when they have the cytokines attached, change into plasma cells, and the plasma cells secrete IgE. So in type 1 hypersensitivity reactions, we're dealing with IgE. And then the IgE attacks antigen and lands on a mast cell, which releases histamine. So this histamine that's being released, that's what these little Y things look like, are the histamine are drawn to the area, and they release other inflammatory mediators. So now we have cytokines, histamines, and lymphocytes that are in the area. Then that causes a lot of different symptoms, things like sneezing, urticaria, which is hives, rhinorrhea is a runny nose, conjunctivitis is watery eyes. It's actually a broad term that can mean more than that, but watery eyes in this instance, and bronchospasm or a cough. Bronchospasm is actually referring to the bronchioles within the lungs, and as they spasm or get smaller, it makes us cough, but it can also make us short of breath. The mild symptoms here, sneezing, runny nose, and watery eyes, aren't that big of a deal. But if we have more severe symptoms like bronchospasm or hives that are causing a bigger problem, then we will have to be much more emergent with our treatment. So An example of an emergent reaction is called an anaphylactic reaction, and this is a very severe hypersensitivity reaction. The causes can be anything from insect stings like bee or wasp, food allergies, medications, could be blood products, could be the dye that we give when we want to do an MRI or contrast media. We find that our patients typically have a real rapid onset or sudden onset. They'll have dyspnea, which is shortness of breath. You might see that sometimes abbreviated as SOB, shortness of breath. Their throat may feel tight. They may have bronchospasms, coughing. They could have laryngeal edema, just what it says, edema at the larynx. They'll feel apprehensive, scared, nervous, unsure. They may have swelling in the mouth, face, throat, or tongue, and itching. And then these symptoms are real severe and are looking at leading towards anaphylactic shock, decreased blood pressure, tachycardia, and loss of consciousness. We'll talk more about that next. So when we're dealing with anaphylactic shock, we're really looking at someone who's already had contact with this allergen at least once. We know they have IgE antibodies already on the surface of the mast cells, and then they begin to have antigens bound to those antibodies. This releases a large amount of histamine. So the histamine is again an important player, but we're talking about a lot of histamine, not just a little. And that excess histamine into the general circulation causes blood vessels to dilate and ooze. It causes irritated nerve endings, and it can cause airway obstruction. Then the blood pressure falls. We have breathing difficulties, and the itching becomes a smaller problem because our blood pressure failing and our difficulty breathing cause poor supply of oxygen to the brain. Our patient will pass out and won't have vital signs to support life functioning unless we treat this patient aggressively. So here's some images of possible anaphylaxis episodes. You can see that patients can have swelling in a lot of different ways. They could have belly aches, but it usually comes with something else as well. We have to do emergency treatment, and we're going to give medications such as epinephrine, antihistamines, and corticosteroids. The epinephrine supports our blood pressure. The antihistamines are going to help get rid of that histamine response, and the corticosteroids are going to help with some of the inflammation, the cytokines and the other mediators that were released, and try to reduce that inflammation. Mechanisms of type 2 hypersensitivity reactions are a little bit different. So now we're at type 2. We're going to find that we have IgG, and that's our problematic issue with type 2 hypersensitivity reactions. And what we see is that there is a target cell that's killed by an effector macrophage or a non-killer cell. And that activates complement in our system. And then the complement target cell is killed by complement-mediated lysis. So when we see lysis, it means the cell has broken, that cell wall has been disrupted, and the contents of the cell are now in the interstitial or intravascular spaces. And then we have receptor-specific autoantibody that interferes with signal transduction. So we're not able to move our signals correctly to other cells. So this is also called a cytotoxic antibody reaction. The antibody is already on the patient's cell surfaces. It's mediated primarily by IgG, but also some IgM. And the complement system is also playing a part. So we see both IgG, IgM, and complement. And then our cells lysis and burst. So we'll see donor cells lysis and burst. The reaction could take hours to a day. We can see kidney damage, reduced blood flow, and blocked vessels because of this. It is frequently because of a blood donor or the incorrect blood type that would have been given to a patient. Type 3 hypersensitivity reactions can either be local or systemic. So local reactions are inflammation caused by the deposits of immune complexes at localized sites. And so we'll have some clinical manifestations at that site. So if it's in the lungs, then our patient is going to show like a inflammation of the lung fields or the pleural space, and it'll be called a hypersensitivity pneumonitis. It could happen in a lot of different places, but it's localized to a specific area. A systemic reaction, our patient will have something like serum sickness. It involves systematic, widespread inflammatory response, and these immune complexes are deposited all over the body. This typically takes a few days to a couple of weeks after an injection. Our patients will have a fever and rash. They'll have excess eosinophils. Their spleen will be enlarged, and they'll have lymph node enlargement as well. Goodpasture syndrome is a type 3 hypersensitivity reaction. And Goodpasture syndrome occurs when particles and antibodies and parts of the complement system damage the basement membrane of the kidney, and no blood can then pass through that anymore because the basement membrane has been compromised, and our patient will end up with a condition called glomerular nephritis, or inflammation of the glomerulus and the kidney cells. So because the blood can't pass through, then we don't have good renal blood flow, and our patient goes into renal failure. Blood transfusion reactions actually occur in 3 phases. Remember, this is a type 2 hypersensitivity reaction, and that it involves IgM or IgG antibodies. So these antibodies bind to the transfused or the donor's red blood cell membranes, and if they're capable of activating the complement system, then we see that the cells begin to rupture or hemolysis. The cells that don't or are not hemolyzed can bind to phagocytic cells through IgG or C3b receptors, and that can stimulate the production of cytokines, but the bound red blood cells are destroyed. Systematic effects include widespread deposits of anaphylatoxins, C3a and C5a, and cytokines that produces clinical signs and symptoms of an acute hemolytic reaction. So what our patients actually exhibit in a blood transfusion reaction: back or flank pain. They can have chills or rigors. Rigors are like when they're so chilled that they are really stiff. They can have a condition that we'll talk about at the end of this semester that's called DIC, or disseminated intravascular coagulation. It actually involves both clotting and excessive bleeding at the same time. They can have a fever, They can have blood in their urine or hematuria. They can have low blood pressure or hypotension. Oliguria or anuria. Anuria means no urine. Oliguria means less urine. Renal failure. They might have pain and oozing at IV sites. So they're going to have some of these things, but they have to have two or more of the column to the right. So they'll have hemoglobin emia and hemoglobin urea. So they're going to have problems with their hemoglobin cells, but they're also going to have hemoglobin in their urine. They're going to have blood plasma that is not the right color, that's not consistent with hemolysis. They're going to have spherocytes on a peripheral smear. That is done in the lab. Their fibrinogen and hepatoglobin levels are going to be decreased, and their bilirubin and LDH levels will be increased. So that gives us a pretty clear sign that this is what's happening. We can also see autoimmune disorders, and the body forms antibodies against itself in this case and causes organ dysfunction. So there's lots of different conditions that could impact any of the body systems. They happen spontaneously. It might run in the family, or there could be a gene connection, but we still don't have really strong connections in most of the cases. We'll talk about a lot of these in future systems when we get into the second half of the class and we break things down by body system. So, for example, Crohn's disease is an autoimmune disorder of the GI tract. We also see diabetic neuropathy is a autoimmune disorder that affects the nerves in people who are diabetic. Multiple sclerosis is an autoimmune disease that impacts the brain and nerve transmission. And there's others listed here. As I said, we'll talk about some of these later on. Probably what's more important about this slide is the triggers. And in all of these cases, there are triggers that can be anything from stress, the temperature of the environment, hormones, food, pesticides, and poisons. Another thing that happens is called molecular mimicry. And this is when our body forms antibodies to an antigen as well as antibodies to body tissue. And then those are mistaken for an antigen. So in rheumatic heart disease, the body forms antibodies against this streptococcus organism, but it also reacts with heart valve tissue. So you'll see that the molecular mimicry has caused, just because they had a strep virus a while ago, now they're having heart valve tissue problems because that mimicry has made their body mistake their heart valve tissue cells for an antigen. So we're going to give you an example of rheumatoid arthritis to just give you kind of an idea of how this happens. We're going to see some molecular mimicry. Typically in rheumatoid arthritis, we don't really know what antigen has caused this yet. So our antigen is unknown, whereas in some cases we know. We believe there's some genetic susceptibility, and they've been looking into that more thoroughly. What we do know is that once this antigen is activated, that our CD4 T cells are activated, and that activates the cytokines and then the rheumatoid factor. In rheumatoid arthritis, we see IgM as the key problematic agent, and then Panus formation is what results, which is a destruction of bone cartilage fibrosis within the joints. So between the accumulation of anti-inflammatory cells and the joint injury because of immune complex deposits, we see that the patient will have more of a widespread systemic rheumatoid arthritis problem. And rheumatoid arthritis can impact the joints, of course, like I've said, but it can also impact other systems, like the heart or the kidneys. So when those immune complexes are actually deposited, the body develops antibodies against the tissue where those immune complexes were deposited. And that's because of some unknown antibody stimulus. But we know that that joint inflammation and the immune complexes is what is causing the deterioration of the joint surfaces. There's lots of other autoimmune disorders, like I mentioned on the other slide. We'll talk about some of these as we move forward. I'm going to show you a few slides to show you just what it might look like. In scleroderma, immune complexes are deposited in the skin and connective tissues, and the skin begins to look stretched and tight without any wrinkles. In myasthenia gravis, antibodies develop against acetylcholine receptors in muscles, and slowly those ACH receptors or acetylcholine receptors begin to degenerate. And so our patients exhibit weakening muscle movement over time, and a lot of times with myasthenia gravis, it begins in the face and then moves to the arms and then spreads from there. So the first noticeable symptom for myasthenia gravis is a weakness of the eye, and it's typically on one side. Speech might be impacted as well. Our patient may have trouble chewing, talking, and swallowing, and eventually the muscles that control breathing, neck and limb movements, or your arms and legs, and they can also be affected. Raynaud's phenomenon is associated with some different types of autoimmune disorders. That's why they call it a phenomenon instead of an autoimmune disorder itself. So you could have Raynaud's phenomenon by itself, or it could be a symptom of another autoimmune disorder. But temperature changes basically how your vessels in your hands and in your toes react. So you might be exposed to cold and your fingertips get really white. That's because the blood in your fingers, the vessels have constricted and you have no blood in your fingers. So where you see this person's fingers like this, there's little to no blood in their fingers. Here and here. And then when those blood vessels dilate again, then the blood's going to rush back in, and you're going to see that they turn dark red, look warm. They can even turn purple like this. Patients have multiple degrees or varying degrees of severity. This also causes pain. It's usually not painful when it's white or blanched. But when the fingertips are full of blood and they're purple or red, it can be very painful. So type 4 hypersensitivity reactions, these, as I mentioned on our first slide, they are delayed. They happen over time or as a result of something that you've been exposed to repeatedly. A lot of times it happens like things like contact dermatitis, like poison ivy rash, or if you're wearing jewelry and you might get a rash underneath of that. It develops after a few days typically. Another example of a type 4 reaction is the TB test, and you'll get that if you haven't had one before you start nursing school. It's a test that is trying to determine if you've been exposed to tuberculosis before. And Of course, if it's positive, then they're going to make sure you get treatment for tuberculosis. And if it's negative, which is what we really want, then we don't worry about it. But the test itself is making a type 4 hypersensitivity reaction. They inject it under the skin, and then if you have a reaction at 48 hours, then it's considered positive. So we're going to talk just a minute about the myasthenia gravis and the pathogenesis of myasthenia gravis. So when we have myasthenia gravis, that's depicted here on the right, and normal nerve discharges are shown on the left. So we still have the same sodium-potassium pump here, but in this image we have antigens that are presenting and then moving into the muscle cells, and that causes poor muscle contractions or no muscle contractions. Here's one of our type 4 reactions for summertime rashes, poison ivy. Lots of different things we can do. Poison ivy, poison oak, and wild parsnips can all cause these. You have to have been exposed to them before and have an allergy to it before you'll get this type of a reaction. The poison oak and poison ivy cause blisters and redness, while wild parsnips is going to cause more of a sunburn type rash, discolored skin. It could have blisters, but they're typically smaller. If you end up with these in the face or airway areas, you definitely need to seek medical attention. So if it's real severe blistering or swelling, if it's around the eyes or the airway, if you have a fever, you definitely want to seek medical attention in all of those cases. So that's the end of this mini lecture. I will post it to Canvas, and please don't hesitate to let me know if you have any questions.